Okie doke, lovely. Welcome everyone. Welcome. So those in the room, those online, welcome to everyone. My name is Andrew Weeks. I'm president of the Liverpool Medical Institution, and we're running this series of lectures on bringing life, which I know many of you have been attending. And we're now on number 17 out of 19, and they are a fascinating series of lectures. We're just collating them with regard to putting them all online so that people can view them at their leisure over time, because it's always been difficult knowing 6 to 7 isn't the easiest time for many people. But thank you for those attending. Thank you for those here in Liverpool for attending online. So very happy tonight that Dr. Clea Harmer has agreed to come and speak to us. Clea, you trained in medicine originally before moving into health management and health strategy, I guess, and then finally ending up as chief executive in, maybe not ending up, that sounds rude, doesn't it? I don't mean to say that. Before reaching a pinnacle as chief executive of SANS, the Stillbirth and Neonatal Death Charity. And you've been there since 2016 now, so 10-year anniversary. So she's also been chair of the Maternity and Neonatal Stakeholder Council and is a member of the National and Neonatal Task Force, which has been set up to implement the findings of the AMOS review when they come out in the next few months. So I'm delighted that you've been able to find time, Clea, to come and join us tonight and give us your thoughts on what can be done to achieve real change in maternity and neonatal care. So thank you, Clea.
Very much indeed. Thank you very much. And I'm absolutely delighted to be here with those in the room and those online. And yes, a really important question, but just to give everybody due warning, I'm not full of answers. I don't have answer to it. What I want to do is put forward some more questions and maybe all of us think a little bit, because this is a really important question. I think it's important because of what's happening today for parents, for healthcare professionals, what we see in the news. And it is the question that a lot of parents and families are asking, and a question that a lot of healthcare professionals are asking as well. And as Andrew said, I am privileged to be the chief executive of SANS, and we therefore focus very much on pregnancy loss and baby death. So I am going to be looking at this question through that lens, but obviously there are those families who have really positive experiences and outcomes. There are those families perhaps who have birth trauma rather than the death of a baby. So all of that is part of this question, but what I'm going to do is through the lens of pregnancy loss and baby death. And that's a really good start. We're not moving the first slide. Is it that one? Oh, we did that. Brilliant. Thank you very much indeed. Thank you. So starting thinking that every day at SANS, we do hear bereaved parents asking this question: what is going to happen with maternity care? Because we have reports, investigations, recommendations, and nothing is changing. And there's very, very clearly sadness for those parents who've been bereaved long ago. They share their stories, they've helped with reviews and recommendations, and yet they still see these headlines, a really sad position to be in. And for their experiences, I think there is a moral imperative to try and understand what is happening, what do we need to do better, that we don't have so many parents in this position. And also, for the healthcare professionals, headlines like this the whole time are very, very triggering for bereaved families, we know. But for healthcare professionals, they're demoralised, exhausted. Even talking to healthcare professionals who feel ashamed of admitting that they work in maternity or neonatal care, which is a horrible, terrible position to have got to. So change has to happen. And I'd like to explore this with you. What does it look like? What do we need to do and to think about? And the way I'd like to structure this is to think a little bit more about why are we asking this question, then explore some of the recurring issues, and then think about what level of change is needed, therefore. So, why are we asking this question? I've said really, obviously, for the bereaved parents, for the healthcare professionals, for parents and families everywhere. But I'm just going to set the scene, really, talking a little bit about the scale and impact of pregnancy loss and baby death. And as I say, this is only one lens, and maternity and neonatal care have far more involved and absolutely very positive outcomes as well. But just for these families, if we think about it, the first thing to note is the latest data is 2024. We are always looking backwards, which means actually the changes that we're making, we don't have that real-time data to understand what is happening. But if we look back to 2024, the latest data, over 4,400 babies were either stillborn or died neonatally. And that's 13 babies every day. That's a significant number. And that doesn't take into account all of those losses before 24 weeks, all of those losses from termination due to medical reasons. And we know approximately 15% of pregnancies before 24 weeks were lost. The fact that we have to say approximately highlights an issue there as well. They're not counted. And I think what is most striking is that 50% of the adult population, and this is a YouGov survey, say that they or someone very close to them has experienced pregnancy loss or baby death. 50% of the population, and yet still we hear people saying when their baby dies, I was the only person this has happened to. So it's a massive issue. And this is rather a basic slide, and it goes back to 2022, but to me, it makes me think of an iceberg. If you're looking at the deaths of children from 24 weeks gestation all the way through to 15, it looks a bit like the iceberg. From 4 weeks onwards, it's tragic, but people are able to talk about those deaths. Nobody talks about the stillbirths and the neonatal deaths. And there's something here about personhood. Are they seen as people? Or maybe not, but they are. They're absolutely, those babies and those families, those babies are part of their families going forward for the rest of their lives. So the scale, the impact, the fact that back in 2016, targets were set to halve the rates of stillbirths and neonatal deaths. And obviously we don't know because we haven't got 2025 data, but we are fairly sure we are not going to hit those. You can see the blue line is stillbirths and the black line is neonatal deaths. And you can see how far off we are from actually reaching that. So we've got an enormous problem, and what's being done isn't actually getting us anywhere near the targets that we want to be. So in summary, 13 babies are dying every day, and that's not taking into account all of those other groups that I talked about. And we've got no data on miscarriage. We know that 8% of babies are born preterm, and all of the risks associated with being preterm and what that means for the families and obviously for the babies themselves. And if we had met those targets, which are achievable because we know other countries are doing far better, 2,500 fewer babies would die. When you think of that, that's 100 classrooms of primary school children. When you think of it in those terms, and people are not talking about this as a big problem, it's a massive problem. And just to highlight, and again, I'm sure you know this, some of the sad detail of those figures, that black babies are twice as likely to die as white babies when it comes to stillbirth. And babies born in the most deprived areas are twice as likely to die as well. So this isn't equal. There are massive inequalities within this. So the scale of the problem is significant. What about the impact? the impact on families. I just want to share again some of the voices of the families who we work with, so you can feel what it's like. I miss my baby every second of every day. And even though the pain will ease and the hurt will fade, I will always, for the rest of my life, not have my baby. I lost my 7 babies in the first trimester. There's no point in pregnancy when babies become more real, matter more. There's no date before when women would be okay to lose a baby. So there is no point in pregnancy when you don't grieve. Parents don't need protecting. They need the chance to be parents, provide their child with dignity and create memories. And then just some facts around the impact on mental health. We know grief obviously is a normal response to the death of a baby, but this is often very complex grief that needs very specialist support and care. And we also know that parents go on to experience mental health conditions that actually need specialist help. So if we're looking at this, 1 in 3 women, so a third of women, have significant PTSD 5 to 18 years after stillbirth. And a third of women roughly show PTSD symptoms after an early pregnancy loss. And 62% of men keep suicidal thoughts to themselves after pregnancy loss or the death of a baby. These affect people for the rest of their lives. And what about the financial impact? Well, you've obviously got direct costs and indirect costs and those sort of intangible costs like the loss of life value. But if we just look at the direct costs on an annual basis, miscarriage costs at least £471 million. Stillbirths at least 13.6 million. And actually, again, we don't have the data on neonatal deaths, so we can't say, but you think of all of those neonatal units. In addition, obviously, there are the costs lost because parents are unable to go back to work and reduced earnings. And actually, there are also those longer term costs related to the physical and reproductive mental health needs, which are estimated to exceed £1 billion annually. So when you look at the scale, the impact individually, the impact for all of us financially, this is a really important question, not just to ask, but actually to find solutions to. And solutions are needed, not just identifying the issues. So you will be aware of how many recommendations are around from how many reports. So 28 national reviews and investigations, and that's not even the local ones. Those are the national ones between 2015 and 2023. And what we did, we've got the Sands and Tommy's policy unit, and what we did was a piece of work to pull out the main themes. And that wasn't difficult because the same themes come out of every single report. So we're very good at identifying what the problems are. In fact, it's often described as admiring the issue. We're very good at doing that, but actually that's no good. We know what the problem is. What are we going to do about it? So I hope I've convinced you that the scale and the impact mean that this is something we really need to be thinking about. And what I'd like to do now is explore in a little bit more detail 3 of those recurring themes. I'm going to look at communication, I'm going to look at the culture of safety, and I'm going to look at evidence base. So taking the first of those, communication. Communication is a very wide word, and I want to think about listening, and that's at the basis of everything, about actually seeing the person in front of you and understanding and connecting with them. So you're seeing the person in front of you, not a Black woman, not a woman who may be from a different area of the town than you live in, or somebody you're seeing a person, not a label sitting in front of you. So listening. Listening is the thing that comes out of every single report. Parents didn't feel they were listened to, or parents' views weren't taken into account. And actually, it's not just parents who don't feel listened to. I would say that a lot of the clinical staff don't feel listened to as well, talking to them. A lot of the midwives and more junior doctors say they don't feel listened to when they try and talk about what's happening as well. Listening is really important, but actually listening means listening with respect and with belief. It doesn't mean just sitting beside somebody, letting them talk for a bit and then ticking a box and going, okay, I've done some listening. This means listening to learn, listening to understand, listening to act. And actually, listening helps you to see the person in front of you, helps you to understand who they are, what their beliefs are, connect with them. And listening involves giving time. And time is probably one of the most valuable resources that we all have. And actually, it's an act of respect, giving people the time to listen properly. So I think listening is something that isn't given enough attention or enough value. Listening not just to tick a box, because we all know that listening is important because all of the reports say that, but listening to learn, listening to improve, and listening to act. And the other thing that listening lets us do is hear different sides of the story. Now, you're probably aware of the inquiries that Embrace undertakes, and these inquiries are based on very thorough and detailed examination of hospital notes. And we're part of the Embrace Collaborative, and it's fantastic the work that is done. But the fact that the Embrace inquiries rely on hospital notes means they rely on one side of the story. They rely on the care that healthcare professionals, doctors, midwives feel genuinely and authentically that they have given. Is that the same as the care that has been received? So I hope George Bernard Shaw doesn't mind me using his quote. The single biggest problem in communication is the illusion that it's taken place. And perhaps the single biggest problem with equitable and safe maternity care is the illusion that it has taken place. So to understand actually what care has been given, we need to listen and look at both the care given and the care received. And that's not that anybody isn't doing the very best that they can, but you are looking at a situation from one perspective. And this is one of the bereaved mothers who took part in our listening project. What's the point having a review done when it's not going to be accurate and parents are not listened to? So how are you going to make changes? So that feeling that a review, you're listening, as in I'm sitting and talking, but that's not understanding where I'm coming from and what I have experienced. And the listening project that I referred to was a piece of work that we undertook at SANS a couple of years ago now to sit alongside the Embrace inquiry into Black and South Asian mothers and their babies. And we specifically with this group wanted to hear what their experiences were. So we worked with Embrace and had the listening project was the parent and family view, and we listened to 56 Black or Asian bereaved parents. And we talked with them, listened to them in whatever way they wanted to interact with us. And you can see interviews, focus groups, email, WhatsApp, voice notes, whatever they felt most comfortable. And we listened to what they said. And there were 4 themes that came out of this. The first theme, as you'd expect, is about being listened to. They didn't feel listened to. The Black and South Asian parents felt that a lot of this was linked to racism or stereotyping. So instead of being seen as a person, they were seen as a difficult Asian mother or a strong Black mother. They were stereotyped before they'd even started. I think this is quite a powerful quote. I think they could not recognize in me actual fear. They just saw this feisty, strong brown woman. And actually, I was so scared I couldn't speak. I was just like blank. And they kept saying stuff like, you're so brave, you're doing so well, you're so brave. And I just thought, you haven't even asked me if I'm okay. Because if you had asked me, you would know that I am not okay. And this is not bravery, this is fear. The next theme that came across very strongly was this personalized joined up care. And this is the not being listened to and not being seen as a person, and the kind of hostile attitudes of you're making too much fuss, or you should be able to cope with more pain than this, made it much harder for some to develop those trusting relationships. And that goes back to the communication and the listening. How can you develop that kind of trusting relationship if you're not being seen as a person? And there's a quote here that kind of highlights it. Every time I've had a new midwife through my pregnancies, the initial kind of meeting always feels a bit weird because of being an ethnic minority and also Muslim and the way I dress. But then once that initial ice is broken and people understand, like, no, I can, communicate, I can pass my message across. But to have to go through that every time you have a new midwife, a new doctor coming in is absolutely exhausting. The third theme was about communication, about safety and risk. And I felt this was really interesting that, in good faith, midwives were saying you're more at risk. If you're a Black woman, your baby is more at risk. But what is a woman supposed to do with that bit of information if you don't then say, but for you, this means, and what you might be able to do? And parents, all the parents described feeling incredibly anxious when their ethnicity was highlighted, but they weren't given any idea of, for them personally, what did that mean? And they weren't given any different care. And several of them said, if I'm more at risk, why am I getting the same care as everybody else? Which is a very logical question. And I've been told, like, when I had the stillbirth, oh, it's common in Black people, stillborns. What are you supposed to do with that sort of information? And then the final theme was about safety and learning. And particularly Black and South Asian parents describing the review taking place, very, very negative experience, not being helped to be involved, helped to be listened to. But actually, the interesting thing about that is that therefore, when we summarize our reviews and investigations and say, this is what we've learned, actually, a whole section of the population is missing. Because if they're not engaging in reviews, we're not hearing the views of those who are most at risk. So the learning is fairly half-baked. It's a really important issue. How do we help everybody be involved in reviews? What am I going to say? How do I raise it? It's about bringing up something that I've had a horrible life-changing experience. It's like fighting, isn't it? It's like fighting for something that no one's going to believe. And how sad that a woman has to use the word fighting after experiencing the death of her baby to actually be heard at all. And I just feel this is really sad. I feel really bad sharing this with you because I'm sure everybody, this is a sad bit, who's online and in the room doesn't recognize this. But I think until we realize this is what is happening across the UK, these are people's experiences, we're not going to be able to tackle these problems. So to summarize, to support good communication, we must make it easy for healthcare professionals to listen with belief and respect. We must make it easy for healthcare professionals, midwives, doctors, to see people as individuals so that they can provide that personalized care. And we must make it easy for them to empathize so they can communicate, so that they can connect. But And this is the really important bit. Are we showing staff and students that we value these, that these are really important parts of delivering safe maternity and neonatal care? So do we include them in training? Is time given for these? Is there a culture where we show that these behaviours are valued? And are these behaviours rewarded? So if we go back to some sort of management speak, if you like, and Drucker, what's measured improves. And tell me how you measure me, and I'll tell you how I'll behave. And if you look at all of our competency frameworks and all of the KPIs and measurements that hospitals, ICBs, everybody has, nobody has a measurement for listening or for seeing the person in front of you or for empathizing. We're making it really difficult for midwives and health care professionals, doctors, to actually prioritize these behaviors, which I'm sure deep down is what they would really like to do. So we need a system that's set up to support listening, seeing, and empathizing. We need a system that allows them to do this. So the next thing I wanted to look at was the culture of safety. And the first question is, what is culture in maternity and neonatal services? It's a really good question. We all know that there is a definition about values, beliefs, behaviours, practices. There's the usual iceberg picture. And the iceberg is culture, what you see and what you don't see. I'm going to put a different thought to you. Perhaps, actually, it's not neat and tidy with the culture being like the iceberg. It's the sea. It's around us. It's what we're swimming in. It's everywhere, but it's so difficult to hold. It's difficult to change, how much salt, plastic, whatever is in there. And particularly difficult for maternity and neonatal care. So different ways of describing culture for maternity and neonatal care. Organizational culture is what usually people talk about. That's, what people value and believe. And that's about leadership and team dynamics, commitment to safety, support for staff well-being. That's all good stuff, but it doesn't sum up everything that's happening in maternity and neonatal care. There's also a culture around the care given. And that attitude and approach to care. Do we have respect for patient autonomy, evidence-based practice? What are people's approach to relational care? And how do people respond to emergencies? So a different sort of culture, maybe not written quite so, but it's definitely there. And then there's person-centered culture. And this is really important for maternity and neonatal care, because unlike the rest of medicine, this is a cultural and social event. So culture includes cultural sensitivity, compassionate care, the concept of parents as partners, not as patients, and of course, that support for bereavement and trauma. So culture could be described in those terms. And then you could describe culture in terms of learning improvement. Are people open to feedback? Are they using data? Do they learn when something goes wrong? And are they committed to training and development? And then finally, of these different sorts of cultures, there is just culture. And in fact, I've used the quote from NHS resolution, which I think may be sort of controversial, but sums it up. It's not one thing or another. It's the balance of fairness, justice, learning, and taking responsibility for actions. It's not about seeking to blame the individuals involved when care in the NHS goes wrong. Absolutely not about blaming, but it's not about an absence of responsibility or accountability. And I suppose that's what I want to move on to next is there's a lot of debate about just culture and accountability and feeling that they don't sit together. I think they absolutely do. And I think we need to be brave enough to have this conversation. Because if you say, not what is accountability, was, if I say accountability, how does that make you feel? And I've done this in rooms with doctors and midwives. Absolutely defensive, anxious, fearful, angry, and you say it to a room of bereaved parents, it makes them feel, again, angry, but confused. Where is it? Who is it? How do I get it? The emotional response to the word is extraordinary. And I think that shows us that this is something that we need to be focusing on. So it is an obligation or willingness to accept responsibility or to account for your actions. And there's obviously personal accountability and organizational accountability. And we know that in maternity and neonatal care, when something goes wrong, we know the kind of things it should look like, the apologies, the learning, consequences where appropriate. But actually, when a baby is harmed or dies avoidably and parents ask, who is responsible? What's going to change? They're not asking at that point at all because they want somebody to be blamed. They really want to understand what has happened. This is part of their story, their baby's story. They want to understand what has happened and they want to know it won't happen to other people. But often what they get is a system response. They might get very authentic responses from the midwife or the doctor. There's an investigation, but nobody owns it or checks whether anything follows up. There are apologies, but nothing changes. And those headlines that they see in the paper, exactly the same things are happening. Explanations that feel technical or evasive. Well, we followed our policy or process was followed. And the number of times that trust letters say lessons have been learned, and they don't prevent the next tragedy. The next baby dies for exactly the same reason. So the question is why? What is preventing accountability, particularly in maternity and neonatal care? And perhaps there's an unresolved tension around where responsibility lies. As I say, I'm fascinated by how emotive a subject this has become. And the writing and the research around it is quite divided. So we've got Davidson saying, there's a risk that no blame culture discourages individuals' motivation to report mistakes. So actually, no blame is no good. And actually just culture isn't a no blame culture. But then on the other hand, you've got reason saying the system in which healthcare professionals work renders blame of individuals unfair. The system is to blame. So it's nothing to do with individuals, it's the system. So you've got people writing on each side. And then in a way, this is the saddest thing, the Safer Care for All in 22 report. Professionals' fear of being unfairly blamed is to an extent inevitable. You think, it sounds as if everyone's given up and that it's inevitable that people are going to feel, frightened and their whole careers are going to have this enormous black cloud over them. I just don't think it's acceptable to have doctors and midwives working in circumstances where they have that hanging over them. We can't have things that feel inevitable like that. So if we look, in fact, this is another thing where many things can be true at once. There are lots of levels of accountability that have to be acting simultaneously. So individual fairness, that kind of just culture is important. There has to be also system learning. The system does have to take responsibility. Leaders have to take responsibility, and there needs to be that public answerability, not a kind of a justice through the media that goes on at the moment. And at the moment, it feels that if one of those are ticked, everyone goes, yes, it's fine, accountability, that's been dealt with over there, so I don't have to worry. But if any level here is missing, the system either becomes very punitive if you don't have the individual fairness, or it's unaccountable if you're not making sure that these levels are there as well. Obviously, staff then are responsible for how they carry out their roles, and leaders are responsible for whether the system is safe. You can only be accountable for that which you have control over. You can't be held accountable for something you have no control over. And again, these are interesting writing. This is about accountability, not in medicine, but this is about accountability in business. People should not be blamed for honest mistakes, but organizations must still take responsibility for the outcomes they cause. And that balance of both and is so important. Not blaming an individual doesn't mean that no one is responsible, because responsibility is not the same as guilt. And we're in this kind of quagmire in the kind of maternity and neonatal care, but actually probably in the whole of medicine, of the immediate gut reaction to thinking about responsibility and accountability, blurring the fact that you can be responsible, but not guilty, that mistakes happen. And I think having a conversation without people being defensive without people withdrawing into where they should be is what is really needed. So with a culture of safety, we need to ask ourselves some questions. Does the system make accountability uncomfortable, risky, or ill-defined? And I would say with maternity and neonatal care, it absolutely does. People are really uncomfortable, I would say frightened. It's very ill-defined. Everyone will say, oh, I did what I was supposed to, so it must be somebody else's. It sits somewhere else. Do our current structures incentivize that kind of either avoiding taking responsibility because you're so frightened, or displacing it? I did what I was supposed to do, therefore it is somewhere else, especially after avoidable harm. And perhaps parents have this wall of everybody saying, well, I did what I was supposed to do, or, avoiding, they call it avoidance. Is it because there is so much human fear from doctors and midwives, organizational defense, because they're worried about the costs that are going to come with litigation, and structural ambiguity? We've designed a system where nobody's quite sure who's responsible for what anymore. So we need a system that supports that psychological safety, continual learning, and accountability, and not be frightened of that word. In other words, we need a system which has a culture of safety. And then the third bit that I just wanted to talk about was the evidence base. And I don't have so much on this, but it's some really interesting thoughts. We've got a lot of barriers to building an evidence base in maternity and neonatal care, not least that for the last 20 years, research into this area has only got 2% of public and charity health related research funding. That hasn't changed, which I could say a lot about that, but it's obviously not right. We know we're not collecting key data like miscarriages. We know there are ethical barriers. People see real problems with pregnant women being involved, and it's much more difficult than other areas. And as we've said, it's not a medical event like, shall we decide which is the right heart valve to use? And the evidence is there. This is an individualized event and journey that women are on. But because it's difficult to build an evidence base, we have very poor implementation of good practice and variation in care provided. People basically do what they feel works for them. And this debate and disagreement we have about everything, about induction, about whether we should have cesareans, that polarization means that we're not coming together to solve the problems. And uncertainty over the guidelines, are they just guidelines? Should we follow them? Should I actually just look at the person in front of me and give them the care that I think is right? So we need a system that provides consistent and evidence-based care. So those are my thoughts about those three areas. I just want to spend a little bit of time briefly thinking about the level of change that is needed. So summarizing those three statements, we talked about we need a system that's set up to support listening, seeing, and empathizing. We need a system that supports a culture of safety, and we need a system that supports consistent evidence-based care. So we need system change. And in fact, in a way, that was what the task force was set up to look at, was to look at system change. But I think it's not just about a little bit of tweaking system change. And I want to share some of my thoughts. And again, do tell me if you think I'm wrong on this. But the first question is the current NHS structure set up to support maternity and neonatal care? When you think of the model, the NHS was set up for acute medical care. And obviously for some, and the maternity care, that's absolutely what is needed. But is that right for maternity and neonatal care? Where does it happen? It happens in the community, in people's homes. This is pregnancy, birth, postnatal. It happens, yes, in hospitals, but it happens everywhere, not just in one place like heart surgery. And it has lots of healthcare professionals involved, many, obviously doctors and midwives, we've got health visitors, GPs. It's a whole mix of people. So that's just one question. But if we think about going back to that idea of we need system change and the idea of the onion, the outer layer of the onion, and this is going into kind of change management, is about the structures and policies and organization. If you go into the onion, then the first layer in the middle layer is about behavior and working relationships. So if you change the outer layer, you're changing structures. If you change the middle layer, it's about behavior. And right in the center, that one you want to get to, is about those beliefs and assumptions, and to some extent where the power lies for making these changes. And that model, if we think about it for maternity and neonatal care, think about it for the NHS. Think about all of the changes that we've seen just in the NHS. So what happens, because they don't understand the onion model, I would suggest, is that a problem's identified. So maybe, A&E is constantly full, hospital pressures. So the structures are reorganized. They start, instead of going into the middle, they start with the outside. So they have a new body, new policies, but there's very limited middle layer behavioral change. Nobody thinks that there needs to be behavior change alongside it. And the core assumptions remain about whatever is the issue in A&E. And so the problem reappears because you haven't tackled it. You've just taken off the outside of the onion. So the extraordinary thing is the NHS looks on paper, if it's constantly changing, you were going into ICBs here, and then what's the next change? But actually, it remains remarkably unchanged in how it actually operates, because that whole model of change isn't being applied. So here's a really radical idea. Why do we not start with the structure of the NHS and think about how do we adapt maternity and neonatal care to fit into an NHS structure that was designed for acute medical care? Why don't we start at the inside with babies and parents and families? And why don't we design a system which wraps all of that preconceptual care, antenatal care, care during birth, neonatal care, postnatal care, wrap it all round the baby, the parents and the families, rather than them going to 101 different places. So if you're starting at the inside of the onion, where with change management you should, and designing a system, and this goes back to that listening that I was talking about at the beginning, and actually seek to understand those beliefs for midwives, beliefs for parents, beliefs for everybody involved, challenge those assumptions around, is hospital the best place for birth? Is cesarean safer than others? Are stillbirths just one of those things? I would say you could challenge lots of assumptions, find different ways to share the power. And that goes back to the listening with respect and belief and seeing the person in front of you. Then once you absolutely understand, then you can establish the behaviors and relationships that you need to see. You're building on that understanding. And I would say actually what Andrew is doing with these lectures is a significant step towards listening and trying to understand different perspectives, which is why I feel very privileged to be part of this, because it is that listening and that sharing respectfully of different points of view, not sitting in your own silo and saying, I know I've been doing this for however many years. But once you establish the behaviours, finally, then you design the structure and the policies to support all of this. You don't start with moving the deck chairs around on the deck and saying, I think that'll do it all. So my final slide is a quote from somebody called David Airy. Do not seek to change what has come before, seek to create that which has not. And I would say, if there is an appetite and people are brave enough, this is the sort of thing we should be thinking about when we're thinking about how do we change maternity and neonatal care so that it works for everybody, so that families, babies, parents, midwives, doctors, everybody involved can actually really enjoy maternity and neonatal care. Thank you.
Don't disappear, Clea. Thank you so much. Fascinating, challenging, useful. Come and hang on, let's just get ourselves organised here, because the questions will come through on the laptop here. Can I start with the question?
Yes, yeah.
Private healthcare. A lot of the problems you talk about in terms of just come a little bit so we can both be in the picture. Lots of the questions with communication that you talk about don't seem to be a problem in private care, and that's not because somehow those who practice privately are better individuals, or they're more worthy, or they're nicer people. It's just that they've got the time to do that, to give that time, which I think as healthcare professionals we all desperately want to do. We would love to do that, but you've got a long queue of people outside your door. You know that you're then due somewhere else, and so this skipping over listening and sort of hurrying through and yes, because actually to properly listen, you said it, you put it so well about how you've got to not only listen but actually act on those things. So it's not only the time taken to listen, but it's the time taken to act on what you're listening to.
Yeah.
And it's the way to squeeze it in is sometimes, sorry, I can't deal with that. I've got to do the bare minimum. Isn't this all a funding problem, the communication problem? I mean, which comes back to people don't want to pay more taxes, and so we're stuck in a system where we can't put any more into healthcare because we don't have the tax money to pay for it because people don't want to pay more taxes.
Yeah, you see, I think if one designed a different system, we have amazing midwives, doctors. I would say we probably have, and you know, this can be debated. We have enough, but the system and the way that they are allowed to work and the structures around them mean that a lot of the time, for instance, a midwife's booking appointment is spent, you know, taking them, writing things up, making sure that everything's there. And we, part of the stakeholder council, where we have lots of different perspectives. So we have parents, but we also have frontline clinicians, and they describe, especially the neonatal staff, they have often 3 or 4 different systems that they're having to input. And so if they're working clinically, they have to take their gloves off, log in, scrub up, put the gloves back on again, and then it's logged out by the time they do it again. And they say they can it's
absolutely true.
What sort of nightmare are we doing with a system that actually we've probably got, you know, we've never got enough doctors and midwives, but if we use their time in different ways, I honestly don't think this is a funding problem. This is about being brave enough to get a clean sheet of paper and go, what are we going to do? Yeah.
And presumably AI will come into that, because I'm desperate for a situation where I can walk into a delivery room and not have to think, oh, now I've got my password changed, I must speak to IT. You just go in, you have that communication, something is listening to you, and we'll record it, we'll take the notes, get the timing right.
Absolutely.
And all those arguments that happen afterwards about, you said this, no, you didn't, yes, you did, no, you didn't. Well,
it's there. Exactly, absolutely. And it captures then the facts rather than the owned perception of what happened. Yeah, absolutely.
Thank you. Let's take some questions. Amal.
Thank you. Thank you for your talk. It was brilliant. And thank you for amplifying the voices of those most affected. I guess just a caveat, I'm not a medic. I am a lawyer that's interested in how institutions fail because they're most vulnerable, and it doesn't get more vulnerable than being a pregnant woman, does it really?
Yeah.
And so built on Andrew's question, you asked, what needs to change. Is it that we need the political will? And it's different from funding in the sense of when things go wrong, we have all these reports. We may have a public inquiry. We're all waiting Farewell's inquiry on the Countess of Chester to report about that neonatal unit. But even with an inquiry, the recommendations don't change anything unless it's acted on. Now, we saw with the Shipman inquiry, it did lead to changes and validation, training, that one doctor can't sign a death certificate. There was a political will to change things. Here we've got, was it 23 reports?
Yes.
A neonatal nurse convicted of 7 murders and essentially 7 attempted, and the Countess of Chester now has been investigated for all sorts of individual charges, the GNM. Again, it's the organisational structure, but it's the political will to change things. Andrew mentioned about, well, if there wasn't all the short staff and resource issues, we'd have time to listen. When things go wrong from a medical law perspective, we see individuals being scapegoated, patient fatality, the doctor's charged for GNM, that's the end of that. And we ignore all the systemic issues. So that was my first question about the lack of political will to change things. And then the second point, in with it's more of an observation, it was the racism and healthcare point. That racism reflects structural racism in society.
It does.
So in education, we know if you're a young black boy, you're 5 times more likely to be excluded. Criminal justice system, if you're black, you're more likely to be convicted, you're more likely to get a longer sentence. So it's another institution reflected in the structural racism. My concern is we see the increase in reform, the constant media scapegoating of immigrants, and so institutionally we're trying to fight this racism and culture, but we see in broader society actually a rise in fascism. And it's not just in England. So we're having 2 fights, aren't we, really? Because the media's making it worse, I think, the issue of racism. Which is then reflected in the workforce and the institutions. So
So I'm aware that people probably can't hear this online, so I'm going to need to summarise that. No, that's all right. I wanted to keep going because it's so important what you're saying. So the 2 points really were about political will, that this all takes political will, and when will political will come, because that seems to be absent. And then the second one, talking about racism within the NHS being a reflection of a wider society racism, and that you can't deal with NHS racism in isolation. Is that sort of okay?
And I absolutely agree about the political will. And I suppose one of the things that we'd hoped with the task force is that maybe this was the political will channeling into this, and it was about how brave will the task force be? Will they get that clean sheet of paper, or will it just be tweaks around the edges again? I have to say, today's news, I don't know where the task force now is or whether it's going forward, but I absolutely agree that political will is there, and absolutely agree about systemic racism in society. But in a way, just saying, well, it's everywhere, so we can't do anything in the NHS isn't acceptable. And we absolutely, rest of society does need to sort itself out as well, but let's at least make pregnant women and families feel safe and seen and heard.
Thank you. Yes, another question in the room.
You mentioned listening. I ended up in psychiatry and also psychotherapy. Junior doctors, other staff presented cases to me. They'd say that the person had come along saying they were depressed, and then they'd dismiss that. They didn't believe it. They thought it was really a patient wanting to increase their benefits, or whatever it was. So I had to try and get these clinicians to actually take what patients say at face value.
Absolutely. Yeah.
From that point.
Yes.
And it sounds as if it's still a problem. You mentioned, went out, so I'm sorry, but respect for autonomy.
Yes.
Respect for autonomy and autonomy are two different things. Respect is a sliding scale, really. And sometimes we have to respect people's autonomy less. We have to override them in some way. That's not being disrespectful.
Yes, that's a fair point. Yeah. Yeah.
I had the Mental Health Act to take people's autonomy away completely.
Yeah.
So the law
Yes.
that
Yeah.
when it needed to happen. And then there's the question of responsibility, really. I think we've come to a point where who knows who is responsible for what? All these rules, regulations, inquiries, recommendations that come out, it seems to me they set us up as clinicians to be against each other.
Yes.
As doctors, we got blamed for being collegiate, and doctors stand together and never take responsibility. So the GMC changed things, and now doctors are expected to report on each other. Maybe they do, maybe they don't, but it's changed the culture
dynamics
to a rather paranoid culture, I think, where we have to be watching each other. And I think that happens between the various clinicians as well. I do think patients therefore tend to trust us much less now, and they don't know where to put that trust.
Yeah.
Do they put it in the doctor, the nurse, the midwife, the organisation, the law, the NHS? Who? They don't know. I think
so we're hearing, for those online, we're hearing from a psychiatrist in the room who's talking about the importance of listening and how that's not just in maternity but across the spectrum. Made a point that autonomy has its limits, but also then talking about there seems to be a disillusion of responsibility, and with that comes a lack of trust. Is that a fair reflection?
We need to personify this situation
Okay.
again.
Trying to make it. Yeah. Okay. Thank you. Comments on that, Clea? I mean,
no, I absolutely agree with all of that. And thank you. Really perceptive comments.
Can I ask something? I mean, let me just check. There's nothing immediately coming through online, but the in Liverpool we've got a very strong culture of evidence-based care, and I think we've all bought into that in the healthcare. The trouble with that is that it generates all the evidence, all the Cochrane evidence, pulls it all together, and you get an answer, as it were. And that's almost the antithesis of personalised medicine, isn't it?
Absolutely.
And one of the difficulties I find, I know when new consultants come into post, they always come in with great enthusiasm and right, I see I've spent 20 years seeing all the problems well, probably not 20, 10 years, seeing all the problems, I'm now going to make changes. And they get so frustrated because the whole system is so stodgy in terms of trying to, it's so unmobile. It's like a huge oil tanker. But that seems a little bit like people who have had bad outcomes. And they say, well, why I should have been offered a cesarean section because of this or that, or actually this was done wrong. The system needs to change. And in a sense, healthcare isn't set up to change on the basis of an individual experience. Unless guidelines weren't followed, And so that's why the system comes back and says, well, actually,
Guidelines were followed.
guidelines were followed.
Yes,
We can't change the whole guidelines, the whole system, because of your individual case, no matter how sad it was. And that creates a real problem with us as healthcare workers when we see people, because you get where they're coming from, but you
Yes.
can't say, well, sorry, statistically it was going to happen to somebody. Sorry
Yeah,
about that, because that's awful. That's
yeah,
callous.
yeah. Well, I suppose that was what I was trying to kind of pull out in why the evidence base. And again, this is just a kind of putting an idea out there. It needs to be a bit different for maternity and neonatal care, because it's not like, doing the research about the best heart valve and, it's there or not. It is so much more nuanced, because this is a person, this is a life event, this is lots more goes into this. And so actually, do we have the right sort of research and evidence to support how people use guidelines when they defer to personalised care, when maternity and neonatal care is different, and trying to squash it into the same box as the rest of medicine doesn't necessarily work, I would suggest.
No, very true. Thank you so much.
Not at all. It's been a pleasure.
I just want to pick up one thing that one person has talked about better births.
Yes.
And saying, isn't what you've been talking about what was promised what date was better births? Decades ago.
Yes.
Isn't that what we were promised? And that's what we were told was good. That's what we were all looking for, and we've sort of lost our way. Are you saying let's get back to better births?
Well,
this is a report for those online who are not familiar with it from.
I would say if we go back to that kind of concept of change, I think that Baroness Cumberledge did a lot around trying to kind of understand and listen, and came up with what was needed. But that middle level of the onion about changing behaviours and challenging beliefs was skipped, and it went straight to then actually let's put in some structures and policies. This is what women want. Let's create this. And that's why these layers are so important. And I think some of those assumptions weren't challenged, and I think behaviours haven't matched what people felt was possible. Yeah.
Okay, I'm afraid it's after 7, so we do need to call it. We do need to stop it there. But I think this could go. We could go on and on. Actually, that was absolutely fascinating, and I think you've touched on. We've been having this series of lectures, and you've touched on really sections which nobody else has touched on at all. The whole issue of communication, the complexity of getting communication right, especially non-English speakers, is a whole other topic with interpretation services and such like. But how do you try and get communication right? Thank you for touching on that, as well as really putting some flesh on the bones of safety culture and how do we actually do it. Thank you so much.
Not at all.
Very much appreciated. We're going to put this online so people can have a chance to get back, because often with these talks, I get the chance to see them back afterwards, but often you don't get a chance to actually go through some of the depths of the slides. So we'll do that. Next up is Tina Lavender. As the 18th of the 19th. Tina Lavender's coming in 2 weeks' time, same place, to talk about strengthening midwifery globally. You'll know she's done a huge amount to work on global midwifery, and so she's coming from just across the road, in fact, from the School of Tropical Medicine here. And then the final talk is going to be Alex Heasel, who's been sitting on the AMOS review group, and he's coming to talk in 5 weeks' time now, on the 18th of June. He's giving the final talk. The AGM is first, for those of you who are members. So the AGM is first, and then we're going to have the talk from Alex, who's going to talk about UK maternity services, a vision for the future. And let's hope that's not all derailed by the sound that by the news of Wes Streeting's resignation today. So thank you very much. Thanks for all those joining online. Thanks to those coming in person, and we'll see you in a couple of weeks' time.